All right, good morning, everyone. We are gonna get us started. We just wanted to give a few more minutes for some folks to join us. Welcome. This is webinar number 4 of the AACDP webinar series. This title of this webinar is Planning for Successful Programs, and we're gonna have interviews with oral health program directors from across the nation. So we are very fortunate to have this opportunity to meet with you every other week and bring experts to you and bring this interactive platform to all of you. I'm Bahar Amanzadeh. I'm a public health consultant, and I'm here with my colleague, Katie Conklin.
Hi, everyone. My name is Katie Conklin. I'm with UCSS Technical Assistance Center, and I'm going to be helping with the behind the scenes today. Thanks, Bahar.
Thank you, Katie. We have a lot of people helping us through this one, and I know we're going to bring our moderator, Dr. Kumar, in a few minutes to bring our presenters to the floor, our virtual floor. But we also wanted to thank our sponsors, and I also wanted to thank everybody behind the scene, including our planning committee, Sarah Colo at MCH, Joanna Albo from CDPH, and a lot of other people who make this happen. Next slide, please. Thank you. So a couple of housekeeping tips. If the entire meeting drops, check your email for instructions. Don't panic. The webinar slides and videos are available on AACDP website. Here's the link, and we're going to put the link in the chat box as well. So if you see the title of each presentation is bold, and you click on it, and you can download the presentation, and so that you can take notes or whatever you need to do with that. Also, if you need CEs, after this webinar, you're going to receive an email that has a survey. As you see, we have an 85% minimum attendance around 100 minutes of this, so that we can give you CEs. But if you had any questions about that, let us know. Couple of stuff around Zoom. So if you have any questions from the panelists, please go to the Q&A and post your questions over there. And this way we will be able to organize the questions and bring it to our panelists. We are gonna have some time after each interview, after each presentation today, we'll bring a couple of questions, but at the end, we're gonna bring everybody together again and have a panel. Next slide, please. Great. So for any technical questions, please put that in the chat box. And Katie and I and Joanna, we're gonna monitor that and get back to you as soon as possible. Next slide, please. Fantastic. So here's our schedule for our next webinar. Our last webinar is gonna be in a couple of weeks on May 27th from 9 to 11 a.m. Pacific time. And it's gonna be a award ceremony as well as hot topics. So we look forward to seeing you all then. Thank you. And here's our learning objective for today. Today, as I mentioned, we are bringing oral health program directors from across the nation so they can share with you what has been some of their success stories, what have been challenges, and so they're going to learn about how to create outcome-driven programs, and then learn about the success and challenges of running such a program. And also, you will have a chance to understand how to develop an infrastructure and monitor the indicators and outcomes for your program. Thank you so much. So with that, I'm going to bring Dr. Kumar to the floor so that he can get us started with our amazing panelists today. Dr. Kumar?
Thank you. I don't see my slide for some reason, Bahar. Okay, now I see it. Thank you.
Great. No, you're good.
Thank you. I would like to add my welcome to this webinar. Again, good morning. I would like to take this opportunity to thank the panelists, the organizers, especially AACDP, and all the sponsors for supporting this webinar series. This particular webinar that we are putting together was Dr. Myron Alukian's idea. So he wanted to interview successful programs in the United States, especially those that have been in place for a long time. Unfortunately, Dr. Alukian is not here, but he's doing well here. Myron, if you are listening to this, I'll do my job to the best of my ability. but I won't be Myronolokian for sure. One thing though is you will have more time to answer the questions, and my questions will be very brief. So with that brief introduction, what we wanted to cover today are some of the successful elements of program, like policy, infrastructure, and especially school-based programs, and then tracking outcomes in public health programs. So we're going to cover these topics, and we have 4 speakers today. Although we'll try our best to interview the panelists, the format will be not, because of the virtual nature of this program, we have asked all panelists to prepare a presentation. So first we'll ask the presenters to give their opening remarks and presentation, and then we'll follow up with questions at the end. So the presenters, today's presenters are Ms. Mary Pat Burgess. She is Program Director, Chicago School-Based Oral Health Program, and she has been a leader and a visionary in dental hygiene and community oral health for a long time. Our next presenter will be Ms. Ramneet Kalra. She is Director of New York City Oral Health Program, the Division of Family and Child Health. And she joined the program in 2012. That's when I met her, when the City Health Department was transforming their oral health program. Dr. Maritza Cabezas will be our next speaker. She's Director of the Oral Health Program in Los Angeles County Department of Health. She has been with the program since 1998. And then Ms. Prashanti Patel. She's the Director of the Children's Oral Health Program in San Francisco. She's been working with community members, medical and dental professionals, and she created the 2020-2025 strategic plan. Thank you, all the panelists. So our first presenter will be Miss Mary Pat Burgess. Over to you, Pat.
All those responsible for bringing this together. It's an honor to be presenting today and give you a little look into what we do in Chicago for the school-based program for the city. First slide, please. Okay, we can go on. Our program was established in the year 2000 at the request of the school-based, of CPS, Chicago Public Schools. They were for many years doing EPSDT. They didn't feel that it was doing a great deal of help for the children to promote long-lasting health. So a task force was put together and the program was devised and went into its first schools in March of 2000. We provide at this point in time, full oral health services on site for the public school students. We do an exam screening, fluoride treatment, prophylaxis, and dental sealants. During the exam, the children are screened to have oral health status, 1, a 2, or a 3. The 1 is no decay, and we advise that the children see a dentist every 6 months. A 2 is 4 decayed teeth or less, and that's considered referable process for the kids. And then a 3, which is they consider emergent, which is 4 or more decayed teeth, abscess, swelling, pain, bleeding. And that's considered emergency care needs. I will get on to the referral site process in a little bit, but we started out serving just 2nd and 6th grade. We are currently serving all grades from pre-K to 12. We have a program that regulates quality assurance in the schools, and we've developed a referral network case management system for every child that needs to see a doctor due to our screening in the SEALA program. Next slide. The school-based program is financed. I know a lot of people are saying, how can we make this work with this present day as far as dollars and cents and the cost of doing the program? We are a little bit different than a lot of places. Currently, the finance is funded through the Chicago Department of Public Health budget, and that is to run my office. There are 5 members to my office. I have a doctor, I have 2 dental assistants and a dental hygienist, and myself. We have a very small oral health division grant from the state of Illinois, a sealant grant that we use to fund our consent purchases, printing, supplies, and it's an internal, we keep it internal. There was an administration fee that was part of the program for many years to help waylay the cost of the quality assurance and the administration of the case management. In the past couple of years, because of the decrease of student seen and the low percentage rate of Medicaid paid by the state of Illinois for children's dental services, it had become a hardship for the doctors. We were able to work between them, us, and our finance program with the city, and this last year the administration fee was dissolved. Next slide. The Chicago Public Schools.
Bahar, yes. If you don't mind, if you can be just a little closer to the microphone for the sound to be a little more clear.
Okay, sorry.
So, no problem.
The Chicago Department of Public Health are the administrators of the oral health services and CPS. And what that means is that we are, by contract, the ones who can provide oral health services only in the schools through our contracted providers. This was requested by the Chicago Public Schools because they wanted to make sure that we didn't have, fly-by nights come in from out of state, which they were suffering from. We had people come in from Indiana and some from Wisconsin, and they would come in, see the kids, and be gone. So by doing this, it set up a regulatory program for us where we were able to monitor who went into the schools and what they did for the kids in the schools. That was agreed upon by an intergovernmental agreement with Chicago Public Schools and the City of Chicago. And that agreement, first one lasted 9 years. We just went through the newest revision after multiple renewals. Thank you, sorry. Right now, we are currently, or in the 2019-20 school year, we were contracted with 523 schools. 40% or higher Medicaid rate is required for a school to be assigned to an oral health provider. That was a ruling that I had put together because we had to make sure that the doctors who were providing services, and Medicaid was their only financial remuneration for their services, were able to have a chance at being able to bill. So that is one of the requirements. And the other thing is, last year, over 360,000 students were in attendance at CPS, and we were able to see, well, this year, because of everything that's going on, we got cut off in March. So our numbers are really low this year, but in the past, we are averaging between 75 and 100,000 students. Next slide, please. The data collection and tracking is probably one of the things I'm about most proud of. We have worked with our IT system to develop a database that collects the student data. And we have it based off the old CDC SEALS program. They seem amazed that we're still using it. However, we were able to work with them to make changes that the city needed. And it's a perfect foil for us to be able to collect data from the schools and be able to process it, to collect the data, maintain it, and then to also turn around and allow it to give us the needed information for referral. We have complete coverage of services since 2007. And since the school-based program began, over 1.2 million students have received oral health care in the city of Chicago through the public schools, through our health care. Next slide, please. This, I hope you can see this. This is a copy of the face of our data report. As you can see, it has multiple options of data that can be extracted. Race, ethnicity, Medicaid status. We can do it by grade. We can do it by school, community, the wards the schools are in, because in Chicago, that's a very important thing to know. All our data is basically collected by zip code, and it's a zip code of the child's home address, so that gives us an avenue of referral, so we can give doctors in the region area of the zip code where the child lives that has a dental office or a clinic, the children's information, or give the parent them the information so that they can set up an appointment with the dental office. And we are able to select reports for the criteria by that entire list over on the right-hand side. Next slide, please. Collaboration is also a really large part of our program. We collaborate with Chicago Public Schools. We have an excellent working relationship with their Office of Health and Family Care. We are also involved with FQHCs. We made it a point in the last couple of years to go and visit and contact and talk. And they have all been very, very glad and very constant about being a referral site for us. And we also work with Oral Health Forum, the Heartland Alliance. This is a program that is a community-based center that improves oral health. And they also are responsible for case management for us. But one of the also big things that they do is that they have an excellent oral health education program that they created and was sanctified, if you want. So they're the only oral health provider for education in the city's public school system. And they go in and they will provide education for 50 to 60,000 students every year. And then the Illinois Department of Public Health, Dr. Van Canagan, who is the current chief division of oral health, is a very well respected and highly appreciated collaboration that we have because of, first of all, we get our ceiling grant, and also because it's a information sharing process that I think is best, serves both partners. Next slide, please. This is our public-private collaboration. I don't know how many other school-based programs do this. We currently have 15 dental providers who are contracted with the City of Chicago. And every 3 years, we have a request for proposal where we have anywhere from 40 to 65 doctors that will be looking at possibly getting a contract. In, as you see right now, we only take 15. So it's a intensive review process that we have to go through, but I feel it's also probably one of the fairest and easiest ways to provide the doctors with the opportunity to come to the city. We have an extensive quality assurance review program, and that also involves the dental practice people and a case management, which involves a list of 253 private dental offices, I think 10 to 12 FQHCs in the city. We can talk a little bit more, or questions can be asked about this. The doctors are going to the schools with their own equipment. They are required to file data reports with us, and that's how we get our information for the seals. We do not pay them, and now they currently no longer pay us, so it's a Medicaid provision for them. It's worked out well for us, and they're probably some of the hardest working individuals that I know. Next slide, please. This is a slide, oops, we're off the slide in the bottom. Sorry. This is a slide that basically explains our referral network system. We get a consent form and a HIPAA compliance form signed by the parent. The parent at the end of the child's session in the school gets a walkout letter, and it's a snapshot of the child's oral health status at the time they were seen in the school. It leads out of a classification of what their oral health status is, a 1, a 2, or a 3. If they have decayed teeth, it has got a marking. The doctors are marking which tooth is in question in their estimation at that time, so that we don't have a severe conflict when we go to the dentist. We make sure that they understand that it is a snapshot. And then that data is collected, and we process it through a SAS program that provides us with case management student logs. And the student logs are by school, and it gives student information that we collect off their consent and off the seals data. And it allows the person who is making the calls to the parents the opportunity to do all kinds of questions as to how the person is received as far as the referral notice is concerned. We ask them what barriers they have. Do they have insurance? Do they have a dentist? All this kind of information is collected. Oral Health Forum is probably one of the best groups that we have at this time that does that collection of data. They're very intensive. And, but each doctor that sees a child in the school has the responsibility of making a phone call to that child. And that's part of our case management. Like I said, we have dental offices accepting Medicaid at 253. And at the bottom of the slide, I can't see it, but it's going to say that I believe it's going to say that the FQHCs, I think, are 10. Next slide. Okay, this is COVID, and we're having conversations now with the Chicago Public Schools. It's questionable as to, hopefully not if, but when. It's possible it might not be until January of 2021. They're considering the School Bear program right now as an essential service. This is just after a meeting that I was at on yesterday. Vision and then our STI program that comes from the health department. They're all trying to figure out ways of getting this back in the school system. And some of the questions that we have, of course, as anyone else, is classroom size, full days and half days, transportation, limited dental stations. We can't have children waiting anymore. They used to bring kids in for ease, not anymore. The other thing is that the schools are also talking about, CPS is talking about whether or not they will have to regulate children going back to school by families. You don't think about stuff like that because you think, oh, okay. But a lot of families are multiple children in the school, and for them to have separate grades where they only maybe do the half days or full days, bigger kids, brothers and sisters, have to care for their siblings. It's a logistic nightmare, and I'm sure everybody that's sitting here that's aware of what's going on with dental right now would understand that it's a very hard thing to be working your way through. Dental consents always used to go out at the end of the school, and then at the beginning of the school year, there's a packet that went out along with other health related issues that CPS used to send. So the question of how that's going to go is also a position we don't know about yet. And then of course the non-aerosol dental procedures, we're trying to follow the ADA, ADHA, and in Illinois, the Illinois State Dental Society has been working with the governor's office to try to figure out the safest way to bring dentistry back into reality, not only in private practice, but also in the school programs. One of the things that was talked about today is that maybe, toothbrush prophies might be one avenue. High speed or low speed handpieces in schools are really, really gonna possibly be a non-entity. And the question about dental sealants too has been brought up as to how can you do that without cleaning a tooth, drying a tooth. You're using an air syringe, you're going to be making particles. So these are all the things that are being discussed and considered and will have a severe impact on our school program. And at this point in time, it may delay us, but I want to say that I don't think it's going to defeat us. So I think at some point in time, we'll figure it out and continue on our way. Next slide. This is my contact information. If anyone is interested, I'll be more than happy to answer these emails or take any phone calls. And next slide. Questions?
Okay. So Bahar and we are going to take turns in getting some clarification from the presenter. I wanted to know, Ms. Burgess, if you facilitate Medicaid enrollment, getting the data, Medicaid number for these providers?
No. The Chicago Public School System has a program internally that is involved with re-enrolling or enrolling students within their school system. The FQHCs, and this is one of the reasons why referral to FQHCs is such a really good idea, is that they have the ability also to enroll Medicaid students or Medicaid families because of their being an FQHC. I don't know too many dental offices that do this, but our system itself is not set up to do Medicaid enrollment.
So one of the questions we keep getting is that, when practitioners go to school, distribute the consent, when they ask for Medicaid number, they don't get Medicaid number from parents. Is that an issue in Chicago?
Absolutely. And even if Chicago Public Schools has the Medicaid number, it's not something they share with us. The doctors have to go to Medi, and they look up the students as they come in so that they can find out whether they have a billable service for them. That's their avenue. We do not have access to that as a school program per se, because it's considered not information we need to know technically, because we don't bill. So, but the doctors have the opportunity to use Medi.
Great.
And they do.
Thank you for that.
I know there are a lot more questions. Dr. Amanzadeh, do you want to go over some of the questions now or later on?
Maybe just one more question for now, and then we will we'll make sure we address the rest for later. But there were a couple of questions around funding, around if the, why did Chicago Department of Public Health decide to fund this, or when it comes to funding, do the FQHCs get any funding through this program? Just elaborate a little bit on that.
The funding right now, and has been since we started, was through our corporate funding, and that was for staffing. So we've always, and when we first started, it also funded our setup, because we originally were going into schools ourselves and found out that very quickly it was way beyond our capability, which is how we started contracting dentists for outside services. The doctors themselves are required by the city contract to supply all their own equipment and supplies. We have, one of the things that we do though is we print extra consent forms so they don't have to take that cost, because they always usually end up what they call papering the school to try to increase the consent population for them to see more kids. But it's, the city took it on to initiate it, and that's where it's always been. We do not have funding. We don't have any other grants other than the city of the school-based oral health grant through the IDPH, and we do not fund FQHCs.
Thank you. And I'm
Thank
sure
you.
more questions, and we're going to get back to those. Dr. Kumar?
Yeah, thank you, Ms. Burgess. I know you started this public-private collaboration in Chicago way before anybody thought about it. And in the 80s and 90s, there was some kind of hesitancy establishing collaboration between the public and private sector. So you were the, I would say, the pioneer in starting this collaboration. Thank you very much. So
thank you.
Our next speaker is Ramneet Kalra from New York City Department of Health.
Good afternoon. Many thanks to Dr. Kumar and Bahar for the invitation to present. The AACDP presentations have been phenomenal, and it's an honor to present to you today. Next slide. So imagine being a program of 1 FTE and given the task to add school-based dental services into a dental public health framework, keeping in mind that the new model should not reinvent the wheel of a previous model in New York City. The new model should also be cost-effective, sustainable, and scalable. This exciting challenge was given to me at the time when my budget only comprised of leftover funds from other programs and when I was a program of 1. So indeed, NYC DOHMH used to operate school-based dental clinics, and due to the underutilization of services and limited cost effectiveness, they were phased out in 2010. In 2012, a dental public health framework was introduced focusing on surveillance, policy, and education. I was hired to lead the framework, and when the commissioners changed in 2014, school-based dental services were added into my portfolio. In 2014, we recognized that the system would be more efficient if it was mobile. It can also be made more cost-effective by utilizing collaborative practices with hygienists and dentists. We therefore educated and encouraged providers to utilize these arrangements to increase reach. During that year, we brought dental services to 105 schools. And by 2019, we scaled our school-based dental services to 798 schools. Expansion of school-based dental services has become a key priority in the oral health program. There are 3 predominant pathways in being able to achieve this mission. 1, by strengthening volume of treatment services through existing providers. 2, by recruiting dental clinicians to participate in school-based settings. And 3, leveraging interprofessional collaboration to strengthen access to dental care. So during today's presentation, we will be talking about our progress in expanding services through these channels. Our mission also includes monitoring and verifying quality of services. We do that by conducting qualitative and quantitative assessments. With the data, we try to address any emergent barriers and assist school-based providers to make programmatic changes when needed. So let's discuss our key program components that have helped drive our mission. Next slide. For the execution of our school-based dental service programs, we identified 5 integral components: direct services and workforce development, education, surveillance and data informatics, quality assurance and improvement, and policy. I will describe each of these program constituents, beginning with direct services. Next slide. Using GIS mapping and on a biannual basis, we assess the geographic distribution of the school-based dental service programs. The maps illustrate an increase in the number of participating schools from 105 in 2014-2015 to 800 school year. The services are currently provided through 16 contracted providers. The maps also illustrate an increase in schools per borough, schools per provider, and in the number of providers between the 2 time periods. So these school-based dental providers include varying clinical setups, such as fixed permanent dental clinics, portable dental equipment set up as temporary dental clinics in classroom space, and mobile dental van. The increased use of portable equipment led to the great increase in school dental services, and it is a model for the vast majority of current care. Next slide. One way to promote equity is to target areas of high poverty, dental profession shortage areas, and schools with high free and reduced lunch rates. The schools participating in the dental service programs were selected based on high free and reduced lunch rates and or if identified as the community. This map further affirms that the dental programs are in fact clustered in high need areas. Next slide. To ensure that key treatments and services are administered, we added specific requirements in the Memorandum of Understanding that we developed with each of the school-based dental programs. More specifically, through the MOU, we mandate the application of sealants and fluoride unless contraindicated. We require quarterly and annual reporting of data, as well as regular updates on activities, and mandate basic case management by the dental provider. We also conduct process and outcome evaluations through quarterly and annual data report, as well as data collected through quality assurance and case management units. We will discuss these in detail. Last but not the least, we also prioritize the review of local, statewide, and national data sets to inform programmatic initiatives. Next slide. To monitor the outcomes of our direct service programs, we developed a data management system and a standardized dental evaluation tool. As a first step, we developed the New York City Oral Health Data Registry. The registry compiled all dental indicators that were utilized by each of our dental programs. We then honed in on indicators that would generate relevant information to us. We then partnered with New York State to establish a standardized tool. The first 8 indicators are for all New York State providers, and all remaining indicators are New York City specific. We required the data to be submitted to us quarterly and annually. With the data, we're able to assess volume of services and evaluate successes and barriers, and address any low rates of services with the providers. Next slide. In order to efficiently track and assess the quality of dental services, we developed a quality assurance unit. Our first step was to establish an electronic checklist with quality measures. The quality measures assess the clinical setup, as well as the participating dentists, hygienists, and auxiliary staff. The sites are randomly selected proportionately by borough. Key findings are addressed in a few different ways. For any urgent issues, we have real-time interventions with the on-site team. For non-urgent issues, we convene with the team leader at the conclusion of the site visit to discuss any concerns. The provider is expected to prepare and implement a corrective action plan. Any immediate issues are expected to be addressed within 24 to 48 hours. Our key findings and the resultant actions are recorded in a tracking database. Next slide. And this is a copy of the aggregated report that we generate using our quality assurance checklist. Each of our 16 school-based providers is given a QA score. While we address any and all issues with the 16 providers, we tend to provide a little more hand-holding to those who fare less than 90%. The goal for our quality visits are not to reprimand the provider for any shortfalls, but to cross-pollinate best practices across dental programs so that they can strengthen workflow and outcomes. Through this report, we also record all issues raised and how they were addressed. Next slide. During the 2018-2019 school year, 6,647 children had urgent need of dental services across 630 schools. Again, 6,647 children had urgent needs. So the majority of urgent cases and a subset of non-urgent cases need to be addressed by a community dental provider. To assist our school-based dental provider with care coordination, we built a case for a case management unit. We developed a comprehensive program plan, hired personnel, conducted literature review, convened with subject matter experts, and developed several case management avenues as well as continuous quality improvement techniques. Among the avenues include a partnership with the dental HMO that holds over 50% of the New York City Medicaid market share. Once we know this partnership is effective, we will move on to a different dental HMO, and with that, we will have control over the 90% of the market share. The dental HMO assists with case management and verifies utilization of care through their EMR claim system. We also designed a partnership with our nursing unit to assist with care coordination. As part of our evaluation, we conducted a survey to assess case management activities by each of the school-based dental programs. We also assess utilization of services through the regular reports submitted by the dental programs. We're also in the process of assessing Medicaid claims data and leveraging our central electronic medical records to not only track our case management work, but to also flag medical providers on children who need follow-up care, more specifically the nurses. Next slide. Identifying and addressing barriers are part of our ongoing quality improvement efforts. One of the key barriers is achieving high consent return rates. The success of school-based programs relies heavily on obtaining parental consent forms. So we therefore conducted a literature review to assess key barriers and motivators and did not find any published data on an incentive benchmark program. Benchmark programs have been deemed successful in strengthening quality of care with health maintenance organizations. So we hence piloted and then scaled a consent benchmark program. As part of this program, we identified the fiscal year 17 consent rates for the participating sites. The blue bars represent these baseline rates. We developed targets for fiscal year 18 that were up to 15 percentage points higher than the previous year. The green and red bars represent these targets. We informed the schools that they would receive $800 or $1,600 if they increased their consent rates by 10 or 15 percentage points, respectively. The schools were held accountable to improve consent form return rates and to receive the awards. This incentive motivated them to develop and implement various approaches. And 39 out of 44 schools that participated increased their consent rates by at least 10 percentage points. Given its success, we plan to roll out the consent benchmark program to 47 schools on an annual basis. Next slide. Another quality improvement initiative is focused on incentivizing dental providers to strengthen volume of treatment services. So this is being done by disseminating portable equipment and dental materials to those who demonstrate its need. We launched a performance-based rewards program to encourage an increase in sealant and fluoride applications. Applicants are solicited contingent on baseline dental service volume information and projections as part of this performance-based rewards program. And then monetary rewards are provided for every additional proportion of sealants and fluoride varnish applied. So we anticipate an increase in the provision of these key preventive treatments, which is among the primary goals of our oral health direct service program. Next slide. One of our other initiatives leveraged medical providers for preventive dental services in 6 school-based health centers. We trained the participating providers on dental screening, fluoride varnish application, oral health education, and dental referrals. To help them remember the workflow, we came up with the acronym SWORT: Screen, Varnish, Educate, Refer, and Track. Since the inception of this program in April 2015 to June 2019, 4,090 fluoride applications were administered by medical providers. This increase is illustrated on the graph on the left. Over the years, the school-based health centers independently scaled this initiative from 6 to 15 sites. The expansion strengthened the demand for our training. To fulfill their requests, we established an electronic training module and made it available on DOHMH's website. Prior to its development, we ensured that there were no other web trainings as such available for school-based medical providers. In our web training, we describe how to best integrate dental services by medical providers during a hectic school day. We've embedded videos, a quiz, and we provide free CME and CNE credits. We had also strengthened dental assessment by school-based medical providers using the CH205 form. The updated form now assesses 1, visibility of tooth decay, 2, urgent need for dental treatment, 3, whether the child visited the within the past 12 months. In the previous iteration of this form, it was just asking whether the child visited the dentist within the past 12 months, but not requesting that the provider look into the child's mouth. So this updated form is used by our Office of School Health clinical staff. It strengthens dental screenings by the medical providers and referrals to the dentist. Next slide. We ensure that our medical providers and the public have ready access to oral health information. Over the years, we have developed several materials to strengthen their knowledge base. We ensure that hard copies are made available in our Literature Fulfillment Center. This allows for providers and the public to order copies in bulk at no cost to them by just calling 311. Next slide. And this would be my last slide for today. As we know, dental disease prevention should begin during the early childhood years. Embedding toothbrushing behaviors at an early age can help decrease the incidence of caries. While National Head Start programs have mandatory toothbrushing, this requirement does not apply to 128,000 children in New York City's daycares. So we conducted a child dental health survey and found that 40% of children surveyed brushed once a day or less. Using data and based on our secondary review, we began our mission to amend R47 childcare regulations to mandate toothbrushing in all childcare centers. If successful, we would impact 128,000 children in daycare. We developed a policy memo, a comprehensive implementation plan, FAQs, training module, and a plethora of other corresponding materials. And at the time, the New York City Commissioner of Health was very supportive in pushing this forward. When the commissioners changed, the priorities also changed. So it is our hope that either the current or subsequent commissioner will give us a green signal to move this forward. And with this, I would like to end my presentation. Thank you.
Thank you, Ramneet. Fantastic.
Thank you, Ramneet. Bahar, is it okay if I ask a couple of questions?
Please go ahead. Yes.
All right. Thank you. Ramneet, you have, it looks like you have a lot of authority to regulate these school-based programs. So where do you get it? Is it a local authority or a state mandate that local health departments regulate school-based programs? So I just wanted to get clarification about the authority that you have. You're dealing with schools, you're dealing with Medicaid program, you're dealing with managed care. So I wanted to get clarification from you.
Oh, absolutely. I would say it's co-authority. And the reason why I say that is New York State Department of Health has equal authority. They review applications as thoroughly as we do, and they have their own set of requirements. Then there's a Department of Education, right? Because I'm in the Office of School Health, we report both to the Chancellor at the New York City Department of Education, and we report to the Commissioner of Health at New York City Department of Health. So we have to also make sure that the school-based dental programs also comply with the requirements of the Department of Education, and then also the Department of Health. So there's this co-authority, and what has really helped us is this great partnership that we have with the New York State Department of Health that has helped us sort of be on the same page when we oversee the performance of the school-based dental programs. And we've come up with this very good workflow where the New York State Department of Health waits for our signature on some of the documents before they go ahead and review the applications, for example. And so, so there's sort of two levels of contracts that the school-based dental programs have. One is with the New York State Department of Health, and they have to meet all of their requirements, IPRO, and then they have to meet the terms that are in our memorandum of understanding with them, and that contract is with the Department of Education Office of Health.
Thank you. I have another follow-up questions, and especially about your benchmark program, and you have created incentives for schools and you have created incentives for providers. So where do you get this money?
Great question again. So we, over the years, have really advocated for the program to grow. And I was able to get a other than personnel budget, OTPS budget, which are tax levy funds, basically. And my sort of goal is to send back the funding that I have into the community, schools, to the providers that are serving these schools, and so on and so forth. And so that's where the funding is coming from. And you know, often we're, on an annual basis, we're looking for ways to sort of recycle it back. And the consent benchmark program funding came from the tax levy funds, and so did the performance-based sealant and varnish program.
Thank you.
Thank you so much.
Bahar, yeah.
Yes, there are a couple of questions in the Q&A and chat box around the data reporting. I know you do quarterly data reporting, and it's just in the scale that you're doing it, it's just amazing to see how it's all coming together. So can you expand on that? Like, how did you decide on quarterly data reporting, and how does it work for you?
Oh, sure. So, you know, it was quite a bit of an undertaking, because we had to work with each provider's data collection platforms and mechanisms. And while some may be electronic, others were paper-based. And so what we did at first was try to get a snapshot of what sort of data is being collected by all the providers. And that's when we created the New York City Oral Health Data Registry. And then once we knew what their capacity is, we came up with indicators that we felt were very relevant to assess. And we worked with New York State Department of Health to get their consent on it. We then went ahead and administered the new evaluation tool, a standardized tool across the board, but then gave the providers a significant amount of time to collect that data. So, you know, if providers didn't have the capacity now, but they would in 6 months, we gave them that 6 months time frame, but we did have a deadline. We worked with them in terms of analysis. So if they provided us very, very raw data and they didn't have the data analysis capacity, then we went ahead and assisted them on that front. If there were any questions in relation to aggregation or, you know, how to appropriately capture the information, we assisted on that front. And then there was a lot of cross-pollination of best practices. So if we know a provider is more successful in one way, we sort of took that information and took it to a different provider that might be struggling on that front. But, you know, because we were able to put in data reporting requirements in the MOU, the providers knew that they had to collect and report the information. And then it was a matter of capacity that they would have to build to report that information. And then it was our sort of partnership with them that, you know, gave them the extra buffer time if needed. But at this point, we get information on every indicator that's requested by each of the providers. So we've been sort of overcome any barriers that we faced.
Great, thank you so much. And I'm sure there's going to be more questions as we get to our panel. Much gratitude to you. And Dr. Kumar, please introduce our next.
Thank you. So our third presenter is Dr. Maritza Cabezas.
Oh, good
Maritza.
morning. Yes. Yes. Good morning. Good morning. This is it. Okay. Would you change the next slide? Do I change?
Yes. It's good, everything. Fantastic.
Okay. Good morning, everybody. I am Maritza Cabezas. I am with LA County Department of Public Health, and I am going to share with you the impact of California tobacco tax proposition 56 and the huge impact it into the oral health for Los Angeles County residents. Next, please. So since 2009 through 2016 was myself and my secretary trying to provide some kind of public health infrastructure, dental public health infrastructure in LA County. But in 2018, everything changed. And since I was asked to talk about infrastructure, you can see that now we have an infrastructure to provide public health services in LA County. This team that you see on your screen has changed, but we are lucky enough to have, please mention who is question. Okay, I'm sorry, I saw a note, I didn't know it was for me. I'm blessed enough to have an excellent staff from dentists to epidemiologists, and we are still trying to fill all the positions. Next slides, please. But let me talk a little bit about Prop 56. I'm not sure how much you're familiar with Prop 56. It's a $2 tobacco tax that passed in California. And I'm not so sure if you can see, but that's a map of the tobacco tax around the country. And I usually like to share that when we passed $2 in California, we're still behind New York. New York is the highest tobacco tax at $4.35. Followed by Rhode Island, $4.25. And the lowest tax in the United States is from Missouri, only 17 cents, followed by Virginia, 30 cents. So when the $2 tobacco tax passed, it enabled us, California, LA, who is one of the recipients from Prop 56, to do the infrastructure you just saw. One of the goals, one of the charge that we were asked is to develop a community oral health improvement plan that you see in front of you. Was quite an undertaking that we took because this is the first strategic planning done in LA County, and it was very important for us to really understand what the community wanted, not what we thought was important. So please, next slide. So it was a planning process by numbers. We had more than 100 stakeholders helping us engage in this process. We had 9 working group meetings. Each group meeting met 3 times. And remember, LA County is 11 million people. We have 4,000 square mile, and our density is more than 2,400 people per square mile. We are an enormous county. We represent more or less 25%, if not more, of Californians. And LA County represent in the population of California. Next, please. So the planning process, again, was by numbers. We had more than 2,500 hours of stakeholder and partner work to come up with the community. Actually, the slide should be coming now. I want you to remember our strategic planning look. The community health improvement plan took us 2 years to put it together. Next, please. And Dr. Kumar asked me to talk a little bit about SPA because a lot of our work is determined by SPA. As I just mentioned, due to our large size, as I said before, 4,000 square mile and density of 2,400 more people per square mile, the county is dividing 8 SPA. This is to allow us to provide relevant public health service target to specific health needs of the residents in these different areas. So the SPA is really trying to put people with the same needs in together. So when we have 8 SPAs in LA County, and you can see here in front of you, so all our work, we try to break up in SPAs. And that's something when you're gonna hear throughout my presentation, the word SPAs. Next, please. So when we finished our COHIP, our strategic planning, we needed to implement. So I just put an idea here so you understand how we use SPA. For the implementation of the COHIP, and again, I'm using an acronym, so I'm gonna say one more time, Community Oral Health Improvement Plan, our strategic plan, COHIP. It's as I said, was an undertaking. So in order to implement, we put a contract out for bid, and now we created what we call the Oral Health Collaborative Consortium. So it was to start in January. Due to the pandemic, starting April 20th of 2020 and ends in June 30th, 2020. So the OHEC, the Oral Health Consortium, is a partner that is coming to implement the COHIP. And the example I like to say here is the contract will have to report all the objectives based on SPA. So when we design the implementation process, we basically asking the contractor to design to work with spots separately, because those, and when we put two spots together, we call mega spa. So the contractor is going to be working with 4 mega spa, 8 divided by 2, 4, and every action, every objective is going to be really looked into the lenses of that mega spa. For example, the language. Each mega spa has a different English as one language, but they have a second language that not necessarily Spanish. We have many different dialects and languages in LA County. Next. Another project we undertook and is very important to us is community water fluoridation. This is a really great venue to talk to dental public health professionals who understand the value of water fluoridation. Next, please. So here's the map we created with the 88 cities of LA County. And the greens are optimally fluoridated cities in LA County receiving 0.7 parts per million. The blue, which is very few cities, are cities that are not 100% fluoridated, are cities, and again, I always use the example of Compton. Compton is 90% fluoridated, but 10% of these residents receive water from wells, and those wells are not optimally fluoridated. So they are not 100%, but they're 90%. So those blue cities are cities that are almost 100%, but we didn't feel comfortable saying they are fully fluoridated. Those are 5% of LA County is in this category. The next category is partially fluoridated. We have 22% of LA County partially fluoridated. That means that it varies throughout the year. It varies when the city has a drought and they don't use their well water. They buy from a source that is fluoridated. So it varies throughout the year. It varies during droughts. It varies when they buy water, when they use well water. Just for your information, 99% of wells in LA County are 0.3 parts per million. Therefore, they are non-fluoridated wells. There is only one city that has optimally fluoridated well water. And 11% of the county is non-fluoridated. They use the well water that is non-fluoridated, and if they buy any water, it's from non-fluoridated sources. Next, please. So we also embark, and all these projects are really embarking to understand the needs of LA County and to collect data. Data is very important in order to make correct decisions. So we were looking in dental deserts. I don't want to be repetitive, but with 4,000 square miles, it's really important to know where our hot spots are. Next. So what is a dental desert? You're probably familiar with the term food desert. So dental deserts are areas in LA County that you have a high population density, low median household income based on medical income, and no or insufficient dental service. The first map we did was with the support of the CDA analyst, but now as I said in my staff, now we have an epidemiologist. We were able to look at the dental desert in 2019. Please, next step, next slide. So here's the map of the dental desert. I'm gonna show a close-up in a minute, but we were very interested to look in LA County where, if there is funding available, if we have to put efforts, where should be our focus, our initial focus. Really important data collection in order to make plans for where best and more cost effective invest any funding that comes our way. So the next slide is Next slide, please. The next slide is a close-up of the dental desert in LA County. And you may ask what the difference. The pink and the yellow areas are dental desert. The difference is the approaches in those areas will be different. The pink areas in LA County are areas that have already an FQHC or a community-based clinic that have dentists, but insufficient number of dentists. So in the pink areas, for example, we will be advocating for those clinics to expand or to open during the weekend. It's going to be a different approach than the yellow area. The yellow area has no dental at all. So they have indeed FQHCs that are medically only. So when you see those red spots on the yellow area, those are medical clinics. So on the yellow dental deserts, our approach will be not asking, can you extend your dental care? In our yellow spots, we're going to say, can you start dental care? So that's very important for the next steps. The dental desert next steps are based on pink and yellow. No, that's fine. I'm done. Thank you. Another big project, a big undertake was the Los Angeles County Smile Survey. Next slide, please. We need data. Data is, I don't need to preach how important it is for a program that, again, for 8 years was just me and a secretary in here. For the first time, we had funds. So we needed to look at the data. So we did the LA County Smile Survey, was screening kindergartens and third grader in Los Angeles County. Just for your information, the previous survey was done in 2005, so it was long due. UCLA received the contract, was also a bid contract, and UCLA won the contract. And the contract is screening 72 schools total, 72 schools, 33 of Los Angeles Los Angeles Unified School District, LAUSD, and 39 non-LAUSD. Was done, finished in November of 2019. And we are hoping and expecting to release the report in June 2020. Maybe now with everything's happening, maybe August or September. But the hardest part was surveying more than 14,000 kids, and is already done. Was done last year. Next, please. We also really focused in a campaign. We did an oral health media campaign in drinking water. And the target audience was 0 to 17 LA County residents. Always we target lower income. And we were very lucky that we were able to have data that show in LA County the highest rate of soda consumption. So the LA County Health Survey that was done in 2018 asked for their household soda consumption. And so that was the area where we focused our media campaign, our water campaign. So the water campaign ran from October 7 to November 22nd. And you can see here on the left side, there's number 1 and number 2. That's where we put big billboards. Those are major freeway, again, on the areas, the highest rates soda consumption. And on the right side is transit covered map. Those we put in the back of buses, drink water, and there was 75 routes that was chosen based, again, on the LA County Health Survey. Next, please. And this is how the campaign looked. Drink water instead of sugary drinks. Your teeth will thank you. Was also done in Spanish. Okay, next. That's a project that is under, and again, now everything's on hold, but this is a project where we partner with Lava May. People from San Francisco probably very familiar with Lava May because Lava May started in San Francisco. There are mobile showers for homeless residents. And while they're showering and taking care of their hygiene, we are offering temporary partial dentures that are done locally, there on the street. They don't need to go to a dental office. So we bring in dental care where they are. please, next slide. I don't know if I have a slide with the, no. So please, we are doing manual with a 3D scanner. So there is no impression material, trying to really bring technology to where the homeless, which is a problem in LA County, are. I think I don't know about my time, but I believe I finished the presentation. Thank you. Next slide is my thank you.
Thank you so much, Maritza.
I hope I kept the 15 minutes.
You did amazing.
Okay.
Yes.
Thank you so much. Yes. Dr. Kumar, do you have
Thank
any
you.
questions for Maritza?
Yeah, I have a question. So for the audience, if you have comments, questions, please post it on the Q&A, not in the chat box. So Maritza, you
Yeah.
have identified all these deserts and dental deserts. So
Yes.
I'm wondering if you have any plans to address it.
Yeah, and I hate to use acronyms but it's our Oral Health Collaborative Consortium, which is the contract that we started in April 2020. One of their objectives is to reach out to the dental desert areas that have a dental clinic and see how can they help them increase service. That's on the pink area. And also part of the contract is for the OHEC, the Oral Health Collaborative Consortium contract, to look into the pink areas, in the yellow areas, and ask and try to help the medical only FQHC and see how can we help them start providing dental service. So there is a huge contract, the Oral Health Collaborative Consortium, and we try to not only ask them for help with the COHIP, with the strategic planning, but we also ask them to work with the dental desert.
So the reason you have this contract with SPA is because the county is too big to be administered centrally. Is
Yes.
that the reason why you have this infrastructure at the local level within the county to manage some of the oral health problems?
Thank you, Dr. Kumar. Exactly, because the contract was written by Mega Spa. So they're going to have the ability to have a staff in each Mega Spa that speak the language of the area. So they'll be able to hire people that represent that population. And the infrastructure that we have right now would not be able to do that. So the contract is a way for us allow a contractor to hire, and they can do that much faster than in the county system. So, and then June 30 comes, the contract ends, and that way we will not be having the staff in-house if we hire ourselves.
This is great, Maritza. There are a couple of follow-up questions around that, around how you identify the dental deserts, and what are some strategies to overcome the dental shortage areas? Like, are you thinking of incorporating RDHAPs within those areas?
Okay, thank you.
Maybe I brought two questions.
I have a whole
but let's first talk about how you identify the dental deserts.
Exactly. Yes. I have a whole presentation on dental deserts, so I'm gonna
right?
40 slides. I'm gonna try to really concise. You saw the final project, but it's a 2-year project.
Yes.
We look at areas of first high population, and the reason I say that is because the first time we ran the map, we had areas like around LAX and around the port. They came out really strong in the map, and those are areas that are very low population. So the first layer of the map is high population. What I call high population. Remember, LA in average has 2,400 people per square mile, average. In our dental desert, we have 10,000 people per square mile. So our first criteria to be a dental desert, you have to be in a high populous area, 10,000 plus square mile. The second thing, you have to have low income, because if you are able to afford dental care, you shouldn't be part of the dental desert. So income was much straightforward. We use medical eligibility criteria, and that's the second layer. So for example, areas like Beverly Hills in the beginning was part of the dental desert because they have no community clinic base there, just private dentists. So when we put income, Beverly Hills disappear from the map. Pasadena disappear from the areas that have no public service, but they have income. So second level is income. And third level, we analyze current FQHCs. We have 75, and I say it varies every year, 75 FQHCs providing dental care in LA County. So we look at the FTEs and we divide it by the number of people living in the area, and we did a ratio around the FQHCs. So if, let's say, an FQHC had one dentist, so the ratio that they can cover is very small. If they have 10 dentists, like Eisner Pediatric, the ratio that they cover is much larger. So with all that in consideration, we came up with the dental desert.
That's great, thank you. And we will tackle the rest of it in our panel at the end. Thank you so much, Maritza.
Okay, thank you.
Great, thank you. And Dr. Kumar, I turn it to you to introduce our next speaker.
No? Okay, thanks. Thanks for unmuting. So our next speaker is Ms. Prashanthi Patel from San Francisco. As you all know, San Francisco has always been a leader, and they have a campaign to create a generation of cavity-free children. Let's hear from Ms. Patel.
Thank you. Good morning, and thank you to Bahar and Jay for having San Francisco represented here. I'll be presenting on our local oral health program that was long in development before I joined. So I just want to take a quick moment to give credit to all those that came before me and all the collaborators' contribution in impacting the health of our youngest residents. So thank you all. Cavity Free SF is a citywide collective impact partnership that predates the California Prop 56 local oral health program funding that Maritza just described. We're dedicated to achieving optimal oral health for all San Franciscan children. Our goal is to eliminate oral health disparities in particular by influencing policy and establishing systems that provide preventive services and treatment in dental, medical, school, and community settings. We use the 20-year surveillance data as a driving force and work with civic, academic, and community partners to promote these healthy behaviors, to integrate oral health within overall health and increase access to oral health care. Next slide. The data reports you're looking at here are the two figures that have made the biggest impact on our work in San Francisco. We share this across the city in community briefings, to our mayor, to all sorts of folks. And when they see that people in their neighborhood, their district, and for San Francisco specifically, their racial groups are impacted the most, they're willing to put in the work to make a change. The disclaimer here I just want to offer for this presentation is that San Francisco is a city and county, for those of you that don't know, and we have one school district. So, and we can easily work with them closely with their school district wellness program and develop the relationship that we have today to really make changes very quickly and also do the kindergarten screening. So this is again our kindergarten dental oral health screening data. And this happens with the collaboration of dentists and the school district. It happened about 20 years ago, and it just was a way to get a snapshot of what the oral health trends were for our San Francisco children. The data drove the creation of our collaboration and the strategies that we take to reduce the rate of childhood cavities. Dental services provided SFUSD services with these 40 dentists from the San Francisco Dental Society, as well as other private dentists. They receive a standardization training prior to beginning screenings each year. The data is entered into Microsoft Access, which later gets analyzed by our epidemiologist and is now able to create these internal and I believe external Tableau dashboards with these images and over time we will hopefully be able to show each of the years where you can scroll over San Francisco and see the rate of change from each year. This data again proves the work that we have to do with the intention of reducing that gap of disparities in the left graph between children of color and that lower line, which is white children. We use this data to prove the need and to provide oral health education and preventive care services where children frequent early and often. So next slide describes how we've recently revised our plan to have 6 strategies. Increasing access where children are, which is place-based, mostly in childcare and school settings. Increase access to dental services in the traditional setting at community-based clinics, private dental offices, hospital dentistry for children with special health needs. Integrate oral health into overall well-being at over 7 medical health systems in San Francisco, providing pediatric care, promotion, and health education, and focusing on our priority populations, Latinx, Asian, and Black communities, including increasing shared measurement and developing a common agenda with other health promotion efforts. The surveillance of our children's oral health status in San Francisco includes the evaluation process of our process and our impact outcomes. And of course, lastly, coordinating all of these efforts, including providing contracting to the task forces and supporting our community and supporting them with their technical assistance. So this panel's focus, next slide, is to discuss school-based services. So I'm going to expand a little bit on what we do at this different school settings. So in addition to the kindergarten dental screening program that fulfills the requirements of the COA, partners in a collaborative such as the Dental Society and various private dentists screen and provide fluoride varnish to preschoolers at the school district, serviced and coordinated by one RDH at DPH Dental Services. The Preschool for All is coordinated and serviced by the Child Care Health Program, part of MCAH and the Department of Public Health, and Head Start community clinics. Or Head Start is serviced by community clinics, including the VDH program, the Virtual Dental Home program, most recently at least at the University of Pacific. And then our dental services also screen and provide sealants to 2nd and 5th graders. And all the children that are screened receive care coordination to a dental office, regardless of their dental carry status. This care coordination occurs via the nurses and health workers at the school district wellness program. They split the students by parent language and school location to provide the most personalized education via phone and could support the families in developing dental homes near where the families actually live. Next slide is our funding structure. And there are 4 different pieces here, so I'm just going to go through them very briefly. So the soda tax is the first one here. And originally with the general fund that we had was from the mayor's office. And the mayor's office was solicited and encouraged by the community themselves to say that oral health needs to be funded by the mayor to reduce that disparity gap. And so that was the original funding came from the mayor's office to develop the task forces. A second round from the mayor's office also helped to fund my position as the coordinator for the oral health program. And now we have general fund coming from the soda tax, the $2 that Maritza was describing here in California. The purpose of these tax funds is to reduce the sugary drink consumption, primarily amongst big sodas targeted communities in San Francisco, low-income residents, communities of color, and youth, all who fall in the category of people suffering disproportionately from chronic disease, and as you well know, including dental decay. We used that money to focus on infrastructure for care coordination and the sealant program, as well as capacity building in the community to promote and educate the communities of color on the importance of early oral health care through the task forces. California Prop 56 that Maritza also explained, so I appreciate that, Maritza. In addition to the epidemiologists and other backbone staff and care coordination this coming year, it supports the task forces in developing a media campaign to inform their communities about the health disparities and how they can access dental care more efficiently and effectively. The DTI funds was the Dental Transformation Initiative through the Medi-Cal waiver, assisted the task forces in focus groups to explore the culturally specific barriers facing caregivers with the goal to develop targeted and effective community oral health messaging, which of course is then funded by Prop 56 in their media campaign. And I also want to give a shout out to the private foundations that provided seed funding for strategic planning, collaborative infrastructure, backbone staff, and the citywide briefings to engage a broader network of stakeholders. And that was from Hellman Foundation and the Meta Fund. And of course, I don't want to leave out the in-kind from the department, which includes our dental director, dentist, 2 dental hygienists, myself on the mayor's budget, staff from the Child Care Health Program, staff on the Child Disability and Health Prevention Program, CHDP, and our MCH epidemiologist. It's key to the way that we function in San Francisco that we leverage all these different programs and their current roles and to incorporate oral health as a part of overall health and well-being. So the next page, I want to go into a little bit of our challenges and barriers. And the department has had a history, has had a long hiring history of taking very long to hire staff, as well as hiring freezes, not prioritizing grant-funded positions, and I'm sitting at the DOC, so I hope no one is listening to this. There is also a lack of epidemiologists who are specialists in oral health data, and so one of the things that, we're trying to hire for that position, and one of the things we've been able to leverage here in San Francisco is our dental public health residents from UCSF Dental School for their research projects, quantitative and qualitative, to work on some of our projects within the cavity-free SF. Capitation rates and the lack of priority from the health plans to prioritize and audit fluoride varnish at well child visits in our integration branch of cavity-free SF. And we have worked with them multiple times, and the answer has always been the same. Capitated rates include fluoride varnish, but fluoride varnish is not enforced by them. And going back to school settings, active consent for non-kindergarten screening. So for the sealant and fluoride varnish programs for preschoolers, 2nd and 5th graders, it requires, we have to get this active consent, and it requires a very intentional plan with the community-based task forces to understand why families would deny that consent form. They have to start working on developing a media message that encourages accepting the service from a school setting. And then there is a whole piece about students being out sick and trying to get their consent forms turned in, and then also to be present on the day of that screening to then get their sealant or fluoride varnish. And then one of the last things here is particularly with Head Start, the collaboration that we've had with them. There's 3 Head Start agencies in San Francisco, and they have about 30 sites overall. And the staff turnover, prioritization of dental, documentation of oral health assessments from dentist office, they don't match the way that we track it within the school district preschool sites. And so it's very difficult in terms of data collection and standardizing it. So for our successes and outcome indicators, which is on our next slide, sorry for the headings, I don't know what happened to them. Task forces is our biggest piece here that has been incredibly important, and it's been a commitment from our supervisors, our mayor, and now our city via the soda taxes for the community-based task forces to provide qualitative research on barriers to accessing dental care and incorporating their findings into our strategic plan, reducing the disparities and addressing the root cause, one of which is racism. Data for the kindergarten dental screening program, all of the data that we collect, even from the preschool screenings and kindergarten and sealant screenings, have really driven our work. And if we didn't have that, we would not be where we are at all. So, and again, preaching to the choir. Care coordination is essential here, and it started off with the support from DTI. And where they were able to have health workers with CHDP to care coordinate medical visits. And now from soda tax, as well as some from Prop 56 for this next year, health workers that are placed at the school district wellness program to care coordinate the children with active dental decay to dentists and to create a dental home. And then lastly, which I think Mary Burgess also talked about today, was the diversified funding to have soda tax, Prop 56, in-kind from the DPH, mayor's budget, DTI, and of course foundation funds. That allows us to change and think about new creative ways and be innovative about how we want to spend our money to address what's most necessary. And I think that's been really a great opportunity for us to think about different ways to support the health of our children from all the different directives. So my last slide, of which I wanted to just quickly talk about, and I was asked to provide some sort of advice on our collaboration with in our local oral health program. So San Francisco's advice on this process, and forgive me, I'm the newbie of the entire team, 3 years in, so I'm observing the great work set before me. What has worked for us, I believe, is getting your data, analyzing it, finding the trends that make your story most compelling. And our story has been the disparities between children of color and white children. Then getting the local political government involved to make their district the healthiest. And then building the partnerships with the medical, dental universities, preschool sites, school district nursing team, and most importantly, CBOs that serve your priority population. You won't be able to provide the equitable services by one person. And then lastly, I'll just go over like the utilization of the collective impact model. And we did this completely unknowingly, but really it is about identifying common agendas. For example, for us, it's reducing caries for children 0 to 5 years old, establish a shared measurement, which is the kindergarten cavities, discuss and clearly post our mutually reinforcing activities. So this is talking about with all the different collaborators that pediatricians will apply fluoride varnish, preschool screenings and fluoride varnish, kindergarten screenings, oral health education across the 0 to 5 year life period, dental homes, also providing fluoride varnish twice a year, toothbrushing. All of those things are mutually reinforcing activities, and folks can see that other people are doing things as well around oral health, which allows them to think that they're part of a bigger, incentive, like a bigger collaborative. And it really does support and give them a backbone structure that there are people that are also working on this. It's not just me. And then regularly updating our partners and non-partners. So that's a lot of internal and external communication. And finally, I really believe this is having that strong backbone structure that really isn't going to have a high turnover. So finding really key people that creates these long-term relationships and institutional knowledge with all the different pieces in your city and county. So sort of my last thing to say is either way, leverage all of your health-related partners across your county. I loved what Ramneet said earlier, to establish a co-authority with your partners. So thank you.
Thank you, Prasanthi. We will invite all the panelists now. Thank you very much, Prasanthi, for that excellent presentation. I cannot think of another county that has health outcome data that has been tracked over the years. And you have given us a great idea for local oral health programs to track outcomes. So, it's not fair that we have given only 15, 20 minutes to each of you to cover such a, the entire program. I hope, you can come back at a later time and describe and discuss in greater depth. But I have one broad question to all of you. It's about addressing disparities. When I looked at San Francisco data, I saw that in spite of doing all these things, disparities persist with respect to income, with respect to age, over time. Although in a 2-decade decline, you still see disparities. So this question is to all the panelists: how are you addressing disparities? And I see that, in New York and Chicago, you're trying, and in Los Angeles, you're trying to identify areas of need and trying to bring in resources to address them. So overall, I want to hear, how are you addressing disparities? Who wants to take the question first?
I can start. So here in San Francisco, we acknowledge the institutional racism that has disproportionately impacted our communities of color across the nation, and particularly in San Francisco. Similarly, in LA, we have dental deserts, and it's all in the southeast corridor of the city. And if you recall the picture that has our map of dental decay in San Francisco, it's along the southeast corridor. And that is where a lot of our families of color live, and that's where we can afford to live. And so what we've done is we've conducted focus groups, partially funded by the Dental Transformation Initiative, in these 3 communities with the highest rates of dental decay for Latinos, African Americans, and the Asian population. And although each focus group had its own set of findings for each racial makeup, we had some common findings, and those findings were that we had a lack of pediatric dentists that speak and look like them or us, and a negative dental experience that is passed down intergenerationally. So a few things that we're trying to do to address this specifically is emphasizing their presence in our strategic planning, and including the voice in all aspects of our program implementation. So, for example, if you look at our strategic plan, we have strategies broken down by objectives, and each objective has, they're not SMART, they're SMARTY. So I don't know if you've heard of that before. So the IE at the end of that is inclusive and equitable. So we want people who we are impacting to be a part of the decision-making process. So they are a part, so inclusive in that decision-making, and then we are creating an equitable result because of that objective. And thinking about and prioritizing giving our funds and our time specifically to those communities that need it the most. So for example, for our task forces is the biggest example. They're able to take their voice from the community, hold meetings that really bring out the struggles that families are facing every single day, and discuss what are the hardships around oral health. And then that is how we incorporate it into our work. So one of the things in the future we'll be discussing with dentists, how we can improve the dentist office itself. Are there people there that speak the language of the families that are mostly impacted by this? Are the offices kid friendly, even if it's a general practitioner's office? So things like that is sort of our attempt at this point.
Thank you. Any other thoughts, ideas?
Okay, go ahead.
We use our database collection because we have the ability to really break down the areas of the city by zip code and then by community. Our schools are laced throughout the city, and it gives us a graphic that we can check to see where there is response, where there is not. Our case management is one of the things that questions asked is barriers. What are your barriers that you have to getting either to a dentist or having services done? All the services in the schools, of course, are free to any of the parents that sign the consent form, so that's not an issue. One of the things you would think that you would see is more applications for the program to continue in the schools, because it does offer a service that is free and can move the child towards health. The south side and the southwest side of Chicago are the areas of higher color, and we are working with Oral Health Forum through their case management programs in those zip codes for several reasons. They have case management caseworkers who have the language that they can have a better and more direct relationship with the families. It's an ongoing process, and it's not an easy one. And we ran into some stumbling blocks, and I'm sure other people did in the past, when they started working on families that were considered a target for ICE. And all of a sudden, a lot of people quit processing their applications for us to see them in the schools. It just, in some areas, it was a total shutdown. And trying to rejuvenate those areas has been a very difficult and very thought-consuming process. And we haven't gotten there yet.
Thank you. Maritza, you wanted to say something.
Yes, because I have a whole oral health disparity presentation I was able to quickly open.
If I may interject for a second, if each speaker can please keep the answers to about 1 minute so that we can bring other questions to the panel.
Okay. LA County has a Department of Public Center for Health Equity. And so we are working with them to look at our data in their lenses of disparity. We learned that oral health outcome is 10% linked to genetic code, but 50% linked to where you live in LA County. So we thought genetic was much higher. And I can share the data with you. I'm looking at it. But genetic only contributes 10%. It's most important in LA where you live than where your genetics. There are 12-year difference in life expectancy if you are living in Walnut versus Lancaster, 12-year difference. So what we're doing is like the dental desert map or the water fluoridation map, we are doing layers of disparity. For example, let me just very quickly, I know we have a minute, but on the water fluoridation map, we put another layer of people can or cannot afford dental care. And there is a huge disparity of people who could not afford dental care. They were the same people not getting water optimally fluoridated. So my short answer to you, Dr. Kumar, is data has to be seen in these lenses. You saw my fluoridation map, doesn't show disparity, but the moment you add another layer of who can afford dental care, who has the highest decay, then you start seeing huge disparities in LA County. And the last thing I want to say is with the SMILE survey, one of the report is going to be looking into areas in LA County that we're going to call, like we call dental desert, lack of service. We're going to look at dental highest decay in LA, and that's going to be our focus areas for the next 5 years.
Thank you.
Okay. It's hard to talk in a minute. Thank you, Dr. Kumar.
Ramneet, your phone is muted, I think. Okay,
thank you.
now you're
And so in 1 minute, targeting schools with high free and reduced lunch rates, and then also targeting community schools, which tend to have a very high dropout rate. And so we really try to prioritize that in our expansion efforts. Also, what we noticed through our literature review is that consents are provided by those who are more highly educated than those that are not as educated, right? And so really strengthening consent return rates is a key priority. One of the things that we have done is create a permanent consent, which is a rolling consent. So a provider does not need to get an annual consent from a caregiver. A consent from previous years is valid. Also, we've translated our consents and our documents into 9 languages so that there increases sort of the outreach. And on a policy front, because there's that effort and focus on policy, is knowing your quality measures for the state and seeing what quality measures that could potentially be added for dental that may help decrease disparity. So for New York, there's only one quality measure, and that's annual dental visit. And that can be met through a screening program in a school, right? And so really focusing on how that quality measures can be strengthened to strengthen the oral health outcomes of your state. And then getting involved and being involved in the whole value-based care discussion, I think is so important, because that too is to focus and aims to decrease disparities. And so that's sort of my 1 minute right there.
I feel like we have to have just a summit around oral health inequalities and just health disparities, and just bring your perspectives. Thank you for that.
right.
Dr. Kumar, shall we go into some of the questions from the chat box?
Yes.
Okay, great. There were a couple of questions about basically how to run a school-based program and some of the details of how you are doing that and the staffing of it, and how do you, how much of your funding goes toward the staffing. Like for New York, there was the question around who does that? Who actually, do you bring the city staff and do you fund them to bring the program in? So let's just start with that, Ramneet.
Yes. So our budget currently is $1.4 million total, and this serves the 800 schools. And now how do we do this? This includes the PS and the OTPS budget. OTPS budget, as I was saying, we try to recycle it as much back to the community. We have contracted, just like Chicago, with Article 28 clinics, which are large providers that are linkages to hospital-based or healthcare facilities. And in order to be able to practice in New York City and New York State, you have to be an Article 28 provider in school settings. It's a New York State requirement. We do not provide any funding to these Article 28 providers. They self-sustain themselves by billing the insurance. They get an APG rate, which is a competitive capitation rate to self-sustain themselves and to help them strengthen their outcomes and hence New York City's outcomes. We have several initiatives, as I was saying, I mentioned a couple of them to strengthen some of the work that they're doing and sealants and varnish provision or provision of case management and so on and so forth. And so that's really how our funding is utilized, and luckily providers do not bill us and we don't provide them any funding. We have 16 contracted providers across the 800 schools that are being served.
Great, thank you so much. Mary Pat, I just wanted to follow up on that, and kind of like some of the questions were around how are you bringing the rest of the dental team to the work? Are there any efforts to bring, to utilize all different levels of dental workforce into your school-based program?
By dental workforce, I'm assuming you mean hygienists, and we have 2 doctors in our program right now that are pediatric dentists. They have their own, everybody carries their own staff. It's a combination of dental hygienists, expanded function dental assistants, and they're responsible for their salaries, all their PPE, anything that's associated with the program is under the single contractor. That is their responsibility. But that's who provides the services in our schools. And then as far as, like I said earlier, my office is myself, who's a hygienist, and I have a doctor. And then we have 2 dental assistants and 1 hygienist. And they are the ones that go out and do the quality assurance throughout the school programs. They're the ones that go out each person that provides a dental sealant gets seen 3 times in a school year. It's unannounced. That way we walk in, we check PPE, we check all their instrumentation, sterilization, according to the CDC and the bloodborne pathogens, and then they do an in-mouth sealant check to make sure that sealants placed are there. And if not, then they have to replace them. And last year, we instituted a new program where they have to file a long-term retention program report, which means that they have to tell us for each child seen the number of sealants placed on which teeth. And they go into a database and they become the comparison factor for the next school year. We are able to track by a student ID number the child who, and whatever sealant they received the year before. And if it shows up that the sealant has been replaced, then we know there's a failure and we move forward as to how we deal with the doctors. It's also a way of doing quality assurance to make sure that the work they do is competent. Great.
You actually addressed another question that people were asking about bringing general dentists into that. So thank you for that. Great. I'll have other questions for you. I'll get back to you in a second.
Okay. Oh, sure.
So, Dr. Kumar, yes.
Yes, I can ask a follow-up question about the presentations. So I think 3 out of 4 presenters talked about case management.
Yes.
It's it is it's a must, but it varies from program to program. So I'd like to hear a little bit more about how you have structured the funding source, how successful you are when it comes to case management, because most of the programs are preventive in nature and they have to be linked to a source of dental care for follow-up treatment. So I'd like to hear a little bit more how you have structured, how successful you are with the case management.
Or / care coordination.
Yeah, / care coordination. I know Ramneet is eager to talk.
And so it's a very, very interesting sort of undertaking that we've recently took on. And I say that because there's so many challenges. How do you reach the parent? Do you have the correct phone number? Do they speak languages that you have, and so on. And so one of the things that we've done, and I talked briefly about it, is create several avenues to sort of meet this underlying goal of getting the child to the dentist. And one is partnering with the dental HMOs, I think is one of the most promising ways to do it. A dental HMO in New York City, the one that we have, DentaQuest, is 50% of the market share. The other one, HealthPlex, holds maybe another 40% of the market share or more. And so partnering with them, a Medicaid patient is either a DentaQuest or a HealthPlex patient. And so if they are involved, they're going to be able to navigate the children to care because they have information that you might not, or the HMO that they're contracted with have information that you may not, and they may have case managers on board that you may not. So that has been something that we're piloting, and hopefully it will be proven successful. Second is really trying to see whether all your efforts are coming into fruition. So we're trying to tap into our salient Medicaid claims data. Based on that, we'd know whether the parent has made some dental service utilization, yes or no. And if that's the case, we can stop bothering the parent. Third is really collaborating with the school nurses and the school medical staff. And one of the ways is that we're sending red flags into their EMR system. So if a child that they're seeing is in need of dental services, they're going to get that red flag and they're going to go ahead and make a referral and then also give a consent. But we also notice that all these efforts are there. There's a lot of efforts being put in. And so maybe trying to close the loop as much as possible while the child is in school is a key priority. So we do provide restorative services. Majority of our programs are providing restorative services, and we have added SDF as part of our scope. And so if providers are willing, we are pushing for SDF to be provided because we know that a child might not get the dental services as soon as we want them to, or ever. And so trying to close the loop as much as possible in a school setting is a priority, but other than that, we're establishing all these various avenues, as I mentioned, and trying to evaluate them as much as possible as well.
Thank you. I'm gonna just push for the time to have a little shorter answers. I know that, again, this wealth of knowledge here. Anybody else wants to answer that question around case management? Yes, Mary Pat.
If I want to. We have, every year we run through a list of doctors in the city of Chicago that take Medicaid. And we check to make sure that they're still viable and still willing. And we, in fact, we just redid it to find out which offices were being opened during the emergent care only due to COVID. It's about 253 dental offices that said yes, they would still be taking clients. And they're on a direct referral list from the dentists that make their own phone calls and Oral Health Forum who makes phone calls. My staff and now the CPS staff also in their health division are making specific schools. They're all assigned different schools now, and they are making phone calls to parents, giving them at least 2 to 3 offices available to them in their zip code of their home. And basically they have to fill out the log, which we have, to give us a response from each doctor, about each child, whether they could reach them, whether they have phone number, et cetera, et cetera. And this is how we're compiling whether or not the child's been touched on a different level. It's long-term data collection, which is unfortunate. And we also provide the list to CPS so that if they have a need in the school, then they also have the opportunity to try to provide something for the child in fast time.
Great, thank you so much. Prasanthi, do you have anything to add to that around the case management care coordination?
Sure. Similar to Ramneet, the care coordination for us also happens through CHDP and the school district wellness program. And so we're using the health worker model. We're at both the school district and within CHDP based on the ethnicity and language capacity actually of our health workers. They receive the referral and then call until the child is set into a dental appointment. And a lot of the times the health workers will actually call and say, would you like me to set up the appointment for you? And they will actually go and make an appointment, call the parent back and say, here's the time that is available. And that has worked very well. We have 3 CHDP health workers that if any issues come up with those clients, nurses will back up and help support the care coordination. And then that also happens at the school district. And the health workers at the school district, we have about 11 of them. And they're all spread throughout the city as well as in all the different various languages that are necessary for San Francisco.
Great, thank you so much. There are amazing examples of how such programs can grow. There are some questions around, I know the amazing data, we know around health disparities, and then around, especially like in LA County, when you know about the dental deserts area, how do we go, where do we go from there? How do we address the social determinants of health that we unravel through programs that we do. And Maritza, I want to kind of bring you on that. Where do you go with that dental desert data as far as strategies that you adopt?
When we developed the map, as I said, we were thinking already not just showing data, but separating them for different approaches. So when we, since we had so much information, it was important to us to really look into clinics that are already existing. Because I think, I mean, I can only talk for LA, but it's not that we have 75 clinics around county. It's not a lot, but it's not a robust, but it's have some infrastructure. So what was happening is they don't have enough dentists. So when we talk about dental desert, it's very important to understand the difference between, but we have areas that have no dental care, not even, and then you can ask me, have you looked at fee-for-service? Because that's also part of the infrastructure providing dental care. And the fee-for-service in many aspects works very well for disparities, because a lot of the dentists speak their language. As Dr. Patel said, it's very important to look like me. So the fee-for-service, some of in areas in LA, we learned that fee-for-service is working. So we're coming up with actually a new map where we are looking at fee-for-service providers and where are they really being utilized, and areas in LA that they have a lot of medical fee-for-service dentists, but they're not utilized. And that's we raise the question, why we have dentical areas that we have enough providers, people are not going there. And they are medical eligible clients. You can say because they're not clients, no. So there is all this disconnect that we're trying to understand, that is not just not having dentists, is why are they not going to the dentists that are available in their community? And I believe, again, I don't, it's just an assumption that a lot has to do with being comfortable to go into a dentist that may not look like me, that doesn't speak the language. And the reason I keep going back to that is because when we were investigating some of the dental offices that were open in garages and really putting patients in harm's way. And if you look at the location, the pictures, like how can somebody even feel comfortable coming here? And the answer was, I felt comfortable with the dentist, which were not a dentist. That the sense of trust, it's where we have to work on.
Great. Thank you for that. Thank you so much, Dr. Cabezas. One other question that I think, Dr. Kumar, and you're saying that it's obvious with the time that we are in, is we are in the era of COVID-19, and things are changing. Impact on our programs, capacity, surveillance, data collection. How can we be innovative about moving forward and all of that? So I just wanted to open that up to everybody to give us some of their expertise on
that. I think Mary Pat described some of the challenges implementing school-based program moving next year. You have already thought about it, or you have already discussed some of the changes that you're going to make moving forward, right?
Yes. Yeah. It's a total, I mean, we have to rely on the Chicago public school system to open the doors. And that's something that is going to be a very hard lift for everybody, no matter where you are and what you're doing. We're going to have to overcome, and I know that hopefully this doesn't sound weird, but we have to overcome the fear of the people that are going to be working in the school programs. Right now, hygienists, dentists, dental assistants are hearing this severe doom that's coming through. Dentists are the fourth most susceptible. Then you have dental assistants, and then you have respiratory therapists, which is number 2, and dental hygienists are the number 1 person most, according to the CDC's recent report, in harm's way of COVID-19 when you're in a practice. So any and all precautions, I know we've always been involved with, the best PPE that we've had during normal times, I guess, if you could call it that. The next ramp to bring that to fruition is going to be something that has to be severely investigated, and unfortunately it's going to be costly. And to try to figure out how that can happen and still function as a school program is going to be a difficult challenge.
So there's a lot of unknown basically as we are going into that.
Absolutely.
There are some questions around how can we kind of look into engaging other healthcare providers in this arena. You know, I kind of just really thinking about integration given our time, right? And Ramneet, I was just curious, given that you do have this expansive kind of involvement of the medical providers, what are your thoughts around using that as a strategy in COVID-19 era?
It can certainly be pushed for, it can certainly be proposed, but I am nervous that the medical providers coming in might not prioritize SWOT, which is the Screen, Varnish, Educate, Refer, and Track. And so we might have to think of more innovative ways on how we can incentivize them or make them motivated in getting more involved. And outside of that, we'd have to actually get leadership approval and buy-in, because dental might not be a priority for them. And so for us, really making the case that dental is an essential service and not be put into a non-essential service is so important to us, so that if they are thinking of a slow roll-in in the fall, it's possible that they might bring in essential and say non-essential services not yet. And so it's something that we would have to consider if we feel that our dental services are being halted for some time being.
Okay, thank you. Anybody else from our panelists has any thoughts around that, around COVID-19 era?
I think for us, the heavy lift will be in the community for advocating for oral health to parents and preventing, emphasizing the prevention. And then again, with like this SDF, fluoride varnish education, providing any preventive care that they can to help alleviate any pressures to like when the kids actually do have severe dental decay, so prevent it as much as possible. So that I think would be the biggest emphasis for pediatricians.
Thank you so much. And we are coming toward our time. We are going to extend our time for a few minutes but Dr. Kumar, any last questions before we close out?
So I have time for one more question.
One more question. Yes.
Oh, maybe I'll ask a generic question of all. What advice would you give to local oral health programs? Any tips, any advice?
I can start. Go ahead, Mary Pat.
Go ahead.
Maritza.
Don't assume you know your population until you go and ask them. The more we do the strategic plan, the more we learn that, and people know what they want, know what they like, and we're learning that trust is a main issue. It's not even income, it's not even I can afford or not, it's trust. That Care Harbor, which people wait all night to get dental care. You probably have the same in your states, the one that you spend all night and get dental, medical, and vision. Most of them have dental insurance, the people attending those events, but they don't trust the dentist. They trust the people at Care Harbor. So that's something we learn. Again, if you don't ask the question, don't assume you know what people are going through, what they want. You need to really go into your population, and especially for us, there are so many different areas in LA. The issues are very different.
I would say the one thing that works and can make it even better is collaboration. Many hands will make the load lighter. And by having others besides yourself, you can reach out to different populations, and you can have people that will connect with them so that they can bring them into the fold and make them understand that what you're trying to do is a benefit for everybody.
Thank you so much. Anybody else has any thoughts around that? Any advice for oral health programs that are starting? I know many of you have probably started small and have expanded to where you are. So a lot to learn from all of you.
And I can add. So me starting with the program of one and not being a dentist, I felt that the stakeholder involvement and engagement was so key. So we created the first New York City Oral Health Task Force, and it was over 30 organizations and over 60 members, and they really helped drive our mission and vision. So that's one. Second, I think having a dental public health framework is super important. So focusing on evaluation, education, policy, direct services. And then I can't emphasize more on the need of evaluation and surveillance. And I didn't really talk about sort of national state and local data sets, but really putting in oral health indicators into those surveillance systems is so key. If you don't have the bandwidth to analyze them, the dental school in your neighborhood might. And also leadership support. Dental sometimes is not prioritized. You have to keep on motivating. I've had so much turnover in my leadership, but I go back with my pitch again and again, and I continue to motivate them. Also, open communication. You want to be able to cross-pollinate best practices. You want to be as open as possible with your partners and with the stakeholders. And lastly, be persistent and be very motivated. I think being persistent, if you know that what you're going to do is going to lead to the outcomes that you desire, keep going for it and just keep moving.
Thank you so much. Just for the interest of time, we have to close. I really thank all of our panelists and Dr. Kumar, our moderator. It was great moderating with you. There's a lot of questions that we were not able to answer, but I just wanted to ask our panelists if it's okay for you all. I'm going to bring those and we can send the group a written answer to all of those questions. If that's
Sure.
That's fantastic. Great. Thank you all for your attention. And just wanted to remind you all that our next webinar is 2 weeks from now, Wednesday, May 27th. And we're going to have an award ceremony as well as hot topics with ADA, MCAH, as well as on fluoridation. So we look forward to see you there. And again, have a great rest of your day. Stay safe and healthy. And see you all soon in person sometime.
Thank you.
Take care. Thank you.
Bye-bye.
Thank you so much. Bye-bye.